Welcome to the breakout session. We look forward to the discussion around technology and the COVID-19 vaccination campaign. We'll be getting started in a few moments. Hello, and welcome to the session, A Monumental Task, Technology and the COVID-19 Vaccination Campaign. As our nation pivots to a vaccination campaign of historic proportions, questions continue to pour in around how many have been vaccinated, where vaccine is needed, and what communities may be experiencing hesitancy. In today's session, we will discuss how public health agencies and their partners work to monitor the United States National Vaccine Campaign and how data systems have evolved to meet the demands of this monumental effort. My name is Kim Martin. I serve as the Director of Immunization Policy at the Association of State and Territorial Health Officials, and I will be helping to moderate the session today. You'll be joining today's session in listen-only mode. A question and answer feature will be enabled for you to chat your questions later. Today, we will first hear pre-recorded presentations from 3 of our esteemed colleagues. And as I mentioned, we will transition into a live question and answer session with our panelists. Before we get started, let me first introduce our panelists. The first panelist for this session will be Rebecca Coyle. Rebecca serves as the current Executive Director for the American Immunization Registry Association, where she oversees the development and promotion of tools and best practices to support the implementation of immunization information systems, or IIS. Next, we will hear from Jim Daniel. Jim currently is the Public Health Lead for State and Local Government at Amazon Web Services. Prior to joining Amazon Web Services, Jim served for almost a decade with the United States Department of Health and Human Services, most recently as the Director of Public Health Innovation for the Office of Chief Technology Officer. Finally, we will hear from Michael Popovich. Mike founded Scientific Technologies Corporation, STChealth, in 1988 and currently serves as the Chief Executive Officer. More information about each speaker can be found in the program. So let's get started with our first pre-recorded presentation from Rebecca at ERA.
Good afternoon, everyone. My name is Rebecca Coyle, and I'm the Executive Director at the American Immunization Registry Association. And today I've been asked to talk about setting the stage for public health modernization, and specifically related to immunization information systems, also known as immunization registries. Today I'm going to set the stage, and I want to focus this conversation really in 4 different areas. So those 4 areas I really hope to try and tackle are data capture, interoperability, policy, and funding. So I'm going to start off by stepping back in time and what pre-COVID or pre-2020 really looked like. So starting with data capture, the graph in front of you depicts the participation by individuals in various age cohorts. Looking at the far right, you can see that in 2019, there were about 60% of adults that were captured in the immunization information system. Again, looking at what's happening today, we anticipate this number is going to increase pretty significantly in 2020. For interoperability, and interoperability is really the exchange of data between two systems. So the exchange of data between an electronic health record system and an IIS. In 2019, there were about 117,000 live connections between an IIS and an EHR. Keep in mind that these are just the systems, and these systems often represent many more providers that operate underneath there. And then this graph on your screen represents 21 jurisdictions that reported their query numbers in 2020. And so the reason why I note this is that often we think about sending information to an IIS, but really this is representing the amount of queries or information that's being pulled down from an IIS, which is really important to note. Moving into the policy section, so it's important to note that each state is responsible for the policies that oversee their system. So there's the opt-in versus opt-out. There's also with whom data can be shared and how that data can be leveraged. It's also dictating which providers or who has to share data with an immunization information system. There are a number of these policies that are all dictated by states. It's important to know that there is no overarching national policy that surrounds any of the IIS. So pre-COVID, IIS were typically funded through the Immunization 317 and VFC cooperative agreements that CDC has with 64 immunization awardees, which include all of the states, the territories, and then some of the larger cities like New York City, Chicago, Washington, D.C. We also know that less than 50% of our jurisdictions have state or local funding, which really limits their ability to make modifications to those systems. So what does the next year hold, or sort of the current period that we're in? I think related to data capture, we will see increased population capture, thinking about the targeted interventions are really focused on adults. And as you recall, there's about 60% of our adults that were in a system prior to COVID. We anticipate that number is going to increase dramatically. One of the key features of immunization registries are the clinical decision support, and this is really the vaccine evaluation, so reviewing a person's immunization history and then also forecasting recommended doses. So taking the COVID example, where there are a number of different vaccines out there that are not interchangeable and have varying immunization schedules. So the example is, you might receive one dose and you need another vaccine, but which vaccine you need, the person may not be able to recall. So being able to query an immunization registry first before administering any of these vaccines is going to be critical. Related to interoperability, again, I think we need to continue to make improvements in our capacity for increasing the number of systems that need to connect. All of the skilled nursing facilities, long-term care facilities, and nursing homes that maybe weren't at the table before are definitely going to be an increased provider of COVID vaccines in the coming future. As far as policy goes, we already know that there are a number of states that have bills before their legislature to change some of those key policies like opt-in to opt-out. There are also some that are requiring reporting, whether that be just for COVID vaccines or all immunizations. There's a variety of new bills out there. And then as far as funding goes, there are currently resources available to add functionality to systems to enhance some of the system capacity. So maybe that's moving from the basement servers to a cloud-based hosting, those types of things. But we also know that this is sort of the boom period when a lot of money gets thrown at the problem. But I think a plan for sustainability following these mass vaccination clinics and the big push to get COVID vaccine out there is desperately needed. So of the functionalities that are being adopted or utilized during this particular part of the vaccine campaign, which of those are critical for moving forward, and what's our plan to sustain those systems after the pandemic? So what can have a lasting impact? I'm using my crystal ball here to try and forecast what I think can have a lasting impact. So related to data capture, again, I think looking out there to determine which partners need to exchange data and prioritizing and getting them onboarded is very critical. Sustaining adult data submission and query. So there's not just a plug and play, but there's also going to be ongoing maintenance of those systems. And particularly for providers that administer vaccines beyond COVID, we certainly want to maintain those connections. So in terms of interoperability, increasing capacity for onboarding new systems that want to connect, and then also exploring new ways to exchange data like the IZ Gateway, which is really sort of a post office, if you will, for being able to exchange data across state lines and from systems that operate in multiple states to be able to send their immunization information to multiple jurisdictions. Related to policy, I think we could all benefit from a national strategy for exchanging data, also for provider reporting, who's going to report, what do they have to report. From a funding perspective, there's a need to modernize our aging systems. Some of these systems have been around for 30 plus years. Some of that technology is old and spaghetti bowl, and we need to modernize. Looking at a plan for the bust period. I talked about the boom period where we throw all the money we can at the problem, but what is our plan for sustaining that long term? So sustainable funding has to be identified or determined for just basic maintenance and enhancements that are needed to ensure that these systems will continue on into the future. And I did get a chance to talk about all these other things that are on the screen in front of you, but I'm happy to answer any additional questions that folks have. With that, I'll just say thank you to ASTHO and particularly the sponsors of this event for being able to present information on immunization information systems.
Hi, my name is Jim Daniel, and I'm excited to talk to you today from my role at Amazon Web Services as the public health lead for health and human services for state and local government. So I wanted to go over some of the things that we're doing at AWS around vaccine management and distribution. And I think the first thing that we always have to think about with anything related to vaccines is our immunization information systems. Right now, I think it's really important to make sure that these systems are stable and can handle the incoming volume that we're going to start having. We know from earlier phases of COVID response that with our electronic lab reporting systems and disease surveillance systems, that with the increased reporting, that a lot of those systems that, let's face it, are about 20 years old now and run on premise were starting to fail. They just couldn't handle the volume of data coming in. And we've helped several of our customers move those applications to the AWS cloud, where they have been able to be stabilized and avoid failures. And now that we're moving into phase 2 of vaccine administration, I think our immunization information systems are going to be facing the same risk with the increased volume that they're going to have. We've worked with great companies like Scientific Technology Corporation's STC already to move. They've got all of their IIS on the cloud, and they're stable. They're able to handle the volumes of query response coming in, and we'll be able to handle the future volumes as we move into phase 2 as well. And, it's really important to think about what's going to happen with phase 2 as we move to a wider population for vaccines. It's not just going to be the reporting of immunizations, the VXU messages, but especially since most of the vaccines are 2-dose vaccines, our systems are going to be hit with a lot of queries as well. So we need to be able to have the capacity to respond to all of those queries and make sure that we're responding in an appropriate time frame so that the providers who are administering those vaccinations can get the real-time information from the immunization information systems as they administer the second dose, what vaccine was administered for the first dose and what the time frame was, so that they can make sure that the appropriate vaccine is administered in the right time. And it's not just the increase in query response that I think that we have to worry about. There are a lot of external stakeholders that are wanting to have access to the data in light of COVID as well. Payers have always been interested in immunization data, but with COVID vaccinations coming, they really want to make sure that they're keeping track of their membership, and they know that immunization information systems are the best place to go to get that information. So we have to make sure that we've got the infrastructure in place, not only to respond to those real-time query responses coming from the providers, but also that infrastructure to allow us to connect with payers and other stakeholders. And AWS has some great services available, like our Lakehouse architecture, that really allows for secure sharing of data with external stakeholders like that. The other part of vaccine administration that we're working on at AWS is the scheduling piece. We saw with the early phases of vaccine administration that the scheduling was a big challenge, especially since we were focused really on senior citizens and vulnerable populations. We found that a lot of the websites out there are confusing to navigate, and even the ones that are really well designed, I think, are often hard for our senior citizens and vulnerable populations to navigate, or maybe they even lack basic internet access. So we've worked with a lot of our customers to implement call centers, and I think what we need right now is we're still focused on senior citizens and vulnerable populations is high touch or concierge-like services with those call centers that allow the general population to call in and actually talk to an agent and get help with scheduling those vaccinations. So we've helped a lot of customers set up those call centers, and the AWS call centers are architected in a way that really anyone with a internet connection and headset can be an agent, and they're highly scalable. They can handle a huge volume of calls, really only limited by the number of agents that you can have handle them. AWS doesn't really supply the agents, but they're partners that we work with that can supply additional agents, or the health department may want to reassign people. So it's a great way to really scale those call center functions. And as we move into phase 2, the other things that the contact centers or call centers can do is really be multimodal, so that they're ready for a more tech-savvy population that might want to interact via voice response or chatbots. So they can all be expanded to that, so we can avoid having all of the calls go to agents, and we can even configure them so that frequently asked questions are answered more automatically, either again through chatbot or automated voice response. And then ideally, we'd like to move into a phase where we're using APIs to work with all of the different provider organizations providing vaccines, so that scheduling a vaccine appointment is more like scheduling a flight, and you've got all of the available vaccine appointments in a single place, where it's a much easier end user experience for the general population as they try to schedule their vaccines. We're doing a little bit in the equity space as well. We have some groups that we're working with that are using the same call center functionality, not only to have calls come in, but to partner with community-based organizations to use that same contact center, call center functionality to push messages out, so that community-based organizations that we know are really one of the best ways to get the messages out about vaccine hesitancy can use that same technology to push out messages that they've received from the public health departments, push those out to their stakeholders in a more automated fashion with automatic calling or automatic text messages. So the idea is to give our community-based organizations some of that digital infrastructure so that they can better communicate with their memberships. And finally, I did want to say a little bit about consumer access. We're working with 2 companies to provide consumer access to immunization information systems. Both STC, Scientific Technology Corporation, and Docket are running on AWS, and have really great phone-based applications where the person can, the end user, the public can authenticate themselves based on information that the immunization information system has about them. And then they can do a real-time query to the immunization information system and bring back their consolidated history, the forecast of when vaccinations are due, and even get that certified or the official immunization certificate so that they can have a proof of immunization. So those are some really exciting things that we're working on here at AWS in this space, but I'm really excited for the conversation to hear what some of your other questions are.
I want to thank ASTHO and Kimberly for inviting me to participate in this panel and being up here with both Rebecca and Jim. And for all of you that know or may not know, Rebecca and Jim combined probably have 45 years of experience in the immunization information system world and public health. So they are true experts. And with that, let me have a few opening remarks here, share my screen, and all righty. I'm going to touch on these 4 items today real quickly in the first 5 or 6 minutes. The very first thing I'd like to do is provide a report card for how well the immunization systems have worked in this infrastructure since the vaccine rolled out in December of last year. And this is a report card based upon what we have seen, what I've seen, working with most of the state public health departments, a lot of the providers and the networks that exist out there, and then dealing with their technology on an everyday issue. You can see in the first few months, the grades went from D, Bs, and down to another D, and they're all improving now since then, and one might expect that. There are no technology infrastructures that really you really know how they're going to operate until they're put under stress. And I can tell you that this pandemic has put a lot of stress on the infrastructure and immunization systems that are out there today, much more than ever existed in the past. And these systems are working well under stress. And although there are a few gaps that have been identified and noteworthy. From this, a couple of quick ones. We all know the appointment scheduling systems are a little bit of a nightmare, to say the least. But the fact of the matter is typically these were not public health environments and technology that was put in play. This is all pretty much new to this particular industry. And the other key thing is that the data in these immunization systems, albeit a lot of data, and that has been existing for a long time, has not really been used as proactively as what was required in this pandemic. So just the situational awareness using data has been one of those challenges, but frankly, it is improving. So there's actually a lot of good news, and we're seeing a lot of improvements going forward. A few surprises that I think have popped up. Maybe they shouldn't be surprises during the pandemic from December on. Number one is that the immunization registries were fairly well prepared. And the reason they were prepared is because when the pandemic got essentially declared back in early of last year, public health had from March to December to ready their infrastructure for whatever vaccine might be developed and delivered. And this required a partnership between CDC, the vendors, the states, ERA, and really all folks that deal with the immunization world out there today to not go out and write new software, but make changes in existing systems so that no matter what the vaccine was, they would be repaired. Another interesting fact, I think, was I certainly have been surprised at how fast data has been reported from the point of care that a COVID shot was giving to when that record shows up in an immunization registry. Early on, it might have taken 2 or 3 days or maybe even a week for information to start flowing in, especially from the larger pharmacies. But the truth of the matter is this is down to daily or in real time kinds of information being reported. I think a big surprise was that the data quality. The emphasis now on collecting data around race and ethnicity are 2 data fields that have always existed in this infrastructure, but never really used. As a matter of fact, with that emphasis, we discovered in our immunization systems that we maintain a bug that had existed for 19 years that nobody really paid much attention to, because race and ethnicity, although was information that was captured, wasn't used until it needed to be used. It uncovered, like, you know what, we've had a software bug that's been around longer than some of my developers that work on these systems. I think another surprise that, great, that the pharmacies and public health folks have had going forward, and now we're seeing many more independents provide immunizations these days. This is a quick screen capture from a real-time dashboard. It shows, if I were to turn this on, every one of those boxes is a patient immunization event being reported from a provider or a pharmacy across the country to one of the immunization jurisdictions. There's over 1 million COVID vaccines being reported daily. If that box is purple, it's a COVID shot for a particular patient. And there's some other information in these. It's very, very interesting. If you were to turn it on, you'd think it was a game, but it's a surprise, but the fact that these systems are handling the volume is a good news. So a few interesting items that have popped up. One is the importance that the pandemic has demonstrated on the value of the data. The second thing is much of the public health infrastructure was designed to support the consumer. Well, in fact, it really is the consumer now that is going to drive the value and use of a lot of these data going forward. And so there will definitely be a shift in not only improving technology in this infrastructure, but how these systems are used and modernized. And we've seen this shift over the last actually 2 pandemics now, but we're on a good track here based upon what exists and how it can be modified. So what does modernization mean? Well, yeah, it does mean improving technology and modernizing and moving to 3rd generation systems. But now we have to look at all this as the value of data and big data and what we could use because the data that exists out there is extremely valuable. So if I were to be asked how can the public health infrastructure be fixed by 2026? I would say, well, if you want to do investments, I would recommend you don't build new, but you renew. And you renew because you have lessons learned and you can bring systems up, fill in gaps. And as long as they're interoperable, friendly, they will interface with all public health environments, not only the immunization systems, but chronic disease, the cancer registries, opioid, you name it, you're on the right track. And most importantly, any investment in a system has to be in an environment that is trusted and trusted by all. So show me the data, tell me what it means, and that's probably a good place to put your money. All right, a few quick pandemic lessons. I think the immunization information systems out there and infrastructure, we were nearly ready, and it has proved itself well. It's handling the volumes under stress, and yeah, there are gaps. We can make improvements. But I think there's a lot of good news. It did take about 6 months for the vendors and the community to get the infrastructure up to speed, and it really is a day-to-day kind of monitoring and keeping up with it. As a matter of fact, all the data electronic exchanges exist are important, but you need people, you need data handlers to kind of ferret out those issues that are occurring, that pop up here and there. Those pharmacies and public health entities that had worked in the traditional vaccine space before, they were better prepared to handle the COVID vaccine, and that was a good thing. And it's also a good thing why many more of the independents want to be involved in traditional vaccines. Frustration clearly was having the very detailed information available. That has been a challenge, but the fact is that data does exist, and once it's uncovered, you really begin to learn a lot. And certainly there are many more vaccine locations and vaccinators now that want to participate. These are all really good things. If we build on that, we build on more integrated system interoperability, we will have a first-class system going forward. So with that, I'll stop, pass it back to Kimberly, and I assume we'll take questions.
Great. Thank you so much, Rebecca, Jim, and Mike, for those excellent presentations, which really helped to set the foundation for a little bit of discussion now. So it was wonderful to hear 3 different perspectives of how far we've come and where we still have to go moving forward. And so we're now going to transition into the question and answer session where the audience will have an opportunity to ask live questions to our panelists. The instructions for how to ask a question are posted. And since today's session is in listen-only mode, the question and answer feature is enabled at the bottom of the screen so that you may chat your question. Please hover over the bottom toolbar to find the QA button and then go ahead and chat your question. So while we're waiting for some more audience questions to come in, I will take the moderator's prerogative to ask the first question. I think during the presentations, you all touched a bit on the Immunization Information System, or IIS, modernization. And so I wanted to ask all members of the panel to elaborate on what are areas of the IIS that might benefit from modernization. And if you were to think about the ideal system 5 years from now, how would it be used, or what would it look like? And so I will start, and that question directed to Rebecca, and then I will ask the other panelists to chime in as well.
Thank you, Kim, and that's such a great question. So in thinking about what the future holds for these systems, I think a lot of what we want to see is continued use of these systems. A lot of this should be behind the scenes. Honestly, we want to see full integration. So regardless of where somebody receives a vaccine, whether it's at a hospital, public health department, emergency room, that provider has access to that information regardless of the environment. So I think there's some, when we talk about modernization, it's not adding new bells and whistles per se. It's really fixing some of the inherent challenges of just aging systems. So updating, I think, the backside of everything. And then I think we have to have some very serious discussions once we sort of emerge from this pandemic about the technology that's been developed through the course of this pandemic, and whether some of that technology needs to be incorporated into the longer vision for an IIS.
Great. And could we now hear from Jim?
Yeah, when I think about 5 years from now, I hope we've solved some of the issues that we've seen that are challenging with COVID-19 response. And I would think, from the provider perspective, that a provider could be able to send out a query saying, I have a patient in front of me who's lived in a few different states, and I'd like to get a history across all of the places where they've lived, and be able to do that seamlessly and have all of the, not only the technical solutions, but the policy in place that would allow that to happen. And also, I would like to, as a consumer, to be able to easily pull a digital copy of my immunization history and use that for whatever purpose I might need that digital history for. And of course, making sure that our immunization information systems are stable and can handle all of the volume that they may be required to be handling by that point.
Great, thanks, Jim. And I'll turn to you finally, Mike, for any words on the subject.
Hey, great, thanks, Kim. Those are all perfect, great ideas, and all would be well received. I have 3 suggestions that I talk about often. First of all, there's a lot of data in these public health registries. They are a significant health data asset of public health. Most people don't even know about it. It is not uncommon to have over 90% of a state's population have an immunization record in one of these systems. And they really, for the most part, are birth to, your whole lifetime. These records are consolidating. And when you get a pandemic, the power of this data and the information is more important. So one of the first things that I like to think where investment should be made in is, how do you make sure the quality of that data is as high as possible standard, so it could really be used to support those individuals in the ecosystem to advance mitigate the mission of diseases. So I would invest in data quality in these systems, and I'd also invest in real-time data quality just coming in. Those will prove very valuable going forward. The second area I think that's really important that the IIS plays is, because they are so significant and the data is so significant, they need to be the cornerstone of the revitalization of the entire public health information technology system, such that the notifiable disease reporting systems, the chronic disease, diabetes, lead programs, WIC programs, cancer programs, whatever those information systems all are, they all need to be interoperable and talk within the public health infrastructure to the IIS. Because there's nothing more important if you're doing chronic disease work, and it's around diabetes, that those patients really are current with their immunization registry. So it's within the public health infrastructure where a lot of funds will be spent, and the IAS should be the cornerstone of that. And thirdly, I think Rebecca and Jim both touched on this a little bit. These systems have been around a long time. Many of them need to go to the next generation. Essentially, we're all built as provider-based systems where providers fed data in and it was collected and then it's used appropriately. But frankly, they need to switch over to be patient-centric. There's a lot of patient data. The individuals need access, like Jim had indicated, to the information. And when you re-architect this, you think of these systems as big data, the big data approach, not the smaller registries that grew out of public health. And then that will allow you to volume and scale, much like the social networks are out there today. So those are three areas that I like to talk about where investment would be valid.
Great, thank you all. So I will now transition into some of our audience questions. Our first question is directed to Jim. So the question is, state health departments all use HL7 to document vaccine to the IIS, but there were no standards in place to manage appointments centrally. What can you do and our vendor and infrastructure or HIE partners do to make this process of supply and demand more interoperable? And so I'll direct that to you, Jim, and then Rebecca or Mike, you can also add in any comments as well.
Yeah, I think that's a great question. And I think a lot of us have seen that the end user experience for scheduling a vaccine appointment is extremely frustrating. When you go to the state websites to schedule your vaccine appointment, you're really just directed out to multiple different websites where you have to go out and find who actually has availability. And one of the really exciting things I think that the Biden administration is doing right now, working with US Digital Services, is to make available an API on available appointments. And that's something that they're planning to get live with pharmacies as soon as possible. I would love to see some of our public health partners that are doing the scheduling for public health run clinics as well, make those APIs available for vaccine appointments in those systems too. It's something that we at AWS can definitely help states consume as that becomes available, so that your websites can actually have real-time information on whether or not there are available appointments. So it's kind of that first step. If you think about scheduling an airline flight, it would be like being able to see all of the available flights, but you'd still have to go to Southwest or Delta to actually book it. But at least you could see where there were available flights before you went out and booked it. But I think the next step coming after that will be APIs to actually do the registration and scheduling too. But just that first step of making the available appointments open is an incredible first step that I'm excited about.
Great, thank you. And any other comments from our other panelists? Oh, Rebecca, I think you're on mute.
I think the only other comment I would make is that I think this is a perfect example of one of those things that we've now discovered is very necessary in a pandemic response like this. But again, is this the functionality that needs to be cooked into these systems for the long term, and what does that cost?
Great, thanks. Okay, I'll move on to our next audience question. And this one is directed to Rebecca to first provide a little bit of context. But the question is, over the past 3 months, I have been working as a volunteer at multiple vaccination sites. It appears that the COVID-19 vaccination clinics are merely perpetuating the disconnectedness rather than promoting data optimization. Is it possible to improve IIS comprehensiveness and connectivity in the absence of a national policy? So again, I'll start with you, Rebecca, and then move on to others as well.
Sure. Well, first of all, I'll say thank you for volunteering in the clinics. We really appreciate that on behalf of everybody in the US. In terms of how to create that comprehensiveness, I think if you'll recall from one of the slides I presented, adult data capture is one of the areas where we don't have the most information about right now. I think maybe the plus side to all of this is that we will gather a lot of that information, meaning that that data will be in there should future vaccines be warranted, and they are every year. flu is very important. So as we go through this process, there's going to be, I think, some learning moments. But I think what's really important to underscore here is the scale to which all of these systems are operating underneath. So in any given year, there's about so just to back up, in 14 weeks, there are about 155 million COVID-19 vaccine doses that were administered. That's 14 weeks. To put that in perspective, that's about 2 years of VFC vaccine ordering. So that's the volume with which these systems are processing. I think no one was quite prepared for this level of volume. When you're doing anywhere from 2.5 to 3 million doses a day just in COVID vaccine, that excludes any other vaccines that are also being administered. So from a scale perspective, we have a lot to go, I think, to get ready and to keep processing. But we're learning a lot from this.
Great. Thanks, Rebecca. And Mike, also, I would like to ask you, could you speak to what you're seeing with the volume of data?
I think that's also a good question. And I'm glad you volunteered. That probably means you got your COVID shot as well. So that's great. So one of the things that I've seen is that these mass immunization events are actually reporting data to the state immunization registries. It's surprising, frankly, to me, how well some of that has gone. The simple fact that if you give a shot, no matter where you are, it has to go to that public health system. So it may not seem as functional, it might seem disparate, but really that data is being captured. And as an example, just from my own personal case, I went to a mass immunization site here in Arizona where I live, got my vaccine, and 4 hours later, I was able to look in the state immunization registry on my iPhone, and I had the digital record of that vaccine showing that I received the Pfizer shot, what lot number, the date and time it was given. And the same thing happened on my second vaccine. But after I put the first one in there, the immunization registry also told me when my next one was due in the series. So it may not seem like it's working, but believe me, it is under the covers.
Great. Thank you. I'll move on to our next audience question. And the question is, could you talk to the last mile in infrastructure in rural areas of the country? I work in areas where records are still on paper and the workforce is overwhelmed at the thought of finding money and time to upgrade. So I can start with you, Rebecca, and move on to others.
Sure. Thanks, Kim. And I think it is a good question. It's hard in rural areas. I live in a state that's very rural, and this is a real thing. It's a reality we all face. I think one positive trend that we've seen are that some of these rural clinics are often being operated by a larger clinic, or they're being acquired by a larger clinic. And so as that process has been happening, we see the integration of technology into those systems. I also want to mention sort of the old-fashioned way of entering data into these systems. So long ago, we used to have to go out to this web portal and we had to log in and we would look up patients and we would input that information. That still exists today, that capability does. And so it doesn't have to be as onerous or as expensive as acquiring a new system. There is really an old-fashioned way of being able to access these systems and key that information in.
And Mike?
One more note there on the upside of the rural areas is that more independent pharmacies are wanting to get into the vaccination game, if you will. It's just not the big chains. There's an ROI for the local pharmacists to do this, not only for COVID, for all traditionals. And so the ability to extend out to the independents in the rural areas, and many of them have pharmacy management systems that in fact are capable of connecting to the state registry. So that brings the data back down to individuals. So by the locals partnering with local public health and the local pharmacies and the independents, you can extend that network. And I think the big issue is it should be nice to have some extra bucks to help facilitate that, push that out.
And I think we have time for one more question. So I'll ask our last audience question. And that is, how can we make scheduling vaccine appointments or receiving a vaccination record equitable when not everyone has a reliable internet service? So I'll direct that to anyone who would like to answer.
Yeah, maybe I'll start. I think, having multiple ways of scheduling your vaccine is very important for those without the internet access or the ability to work the complicated websites. I think it's really important that we have the call centers at the state and even potentially the national level, so that those people have other ways to call and schedule their vaccination appointments. So I think that's something that I think every state has realized and is implemented now. But we've got to make sure that we keep that infrastructure going and that it's scalable, so that people don't get busy signals or have their calls disconnected, that those individuals are able to call those numbers and get their vaccine appointments scheduled.
One of the things this country is good at is we are very community oriented, and there's huge and significant networks that do outreach to all kinds of subpopulations. And by educating them and involving them in this, and then helping them engage with those folks that make the technology piece more difficult, you're actually empowering those communities and those folks that work with them. So I think a lot of continued education and bringing more players into this than one would normally think, and not relying only on technology, is only going to be a win for everybody.
Great. I would like to thank all of our panelists today for their wonderful presentations, and to the audience for asking really great questions. We are just about out of time, so I wanted to mention that up next will be our final plenary session starting at 5. And again, we thank you very much for joining this session today, and we look forward to seeing you in our next session. Thank you.